Okay, let's unpack this. When we talk about breast cancer treatment, the surgery part, well, it's been through this incredible transformation, hasn't it?
Oh, absolutely. It's really a story of moving away from, frankly, brute force
Yeah.
towards something much more elegant, much more precise.
And personalized, too. It feels like that's the core theme now.
Definitely. We're diving deep today into those surgical techniques, specifically drawing from, the gold standard, the latest Schwartz's principles of surgery. We're focusing just on how surgeons tackle the diagnosis and the actual removal of the cancer itself, and also those nearby lymph nodes.
And the big picture here, the main takeaway really seems to be this massive shift. Modern breast cancer surgery is all about getting the best possible cancer control,
Maximum oncological control, yes.
but with the least possible harm, right? Minimal morbidity and aiming for the best cosmetic outcome possible,
Exactly. It's a world away from the really radical surgeries of the past.
which were standard for a long time.
For almost a century, really. The Holstead radical mastectomy was the norm, removing everything, breast, nodes, even chest muscles.
Oof. Tough surgery, tough recovery.
Incredibly tough.
Yeah.
Effective for local control, sure, but the cost to the patient, functionally, aesthetically, it was immense.
So the most surprising thing for listeners maybe is just how much solid evidence we now have that less surgery can be just as effective for survival.
Provided, and this is the crucial part, provided other treatments are part of the plan.
Right, things like radiation, chemotherapy, hormonal therapy, the systemic treatments.
Precisely. The understanding that breast cancer isn't just a local problem, it's potentially a systemic one from early on, that's what changed the game. And the data, especially from big trials like NSABP-B06, backs up this less is more approach when it's appropriate.
Okay, so let's start right at the beginning. How does the diagnosis itself actually guide the surgeon's hand? In the olden days, if you felt a lump, well, finding out what it was often meant cutting it out first, right? The excisional biopsy.
Yeah, that was common.
Yeah.
But that approach for just getting a diagnosis, it's largely history now.
So what's the standard first step?
Needle core biopsy. That's the preferred method, hands down. Schwartz's makes that clear on page 588.
And why is that such a big deal? Why the needle first?
Because it gives the team so much information before the main surgery. You get tissue architecture, you can tell if it's invasive, the grade, and critically, the hormone receptor status, ER, PR, HER2.
All that from just a needle sample.
Yep. And knowing that upfront guides everything. It tells us if maybe the patient should get chemo or hormone therapy first before surgery. Neoadjuvant therapy, we call it.
So you tailor the whole plan from the start, which
Yeah.
means excisional biopsy. It's not really for diagnosis anymore.
Not primarily, no. It's more reserved for specific situations now. Like if the needle biopsy results just don't quite match up with what the mammogram or ultrasound shows or what the doctor feels.
Discordant result.
Exactly. Discordant results. Or sometimes for benign but problematic lesions. But for cancer diagnosis, the needle biopsy is faster, it's less invasive, and it lets us plan the definitive surgery, the lumpectomy or mastectomy, with all the facts in hand.
Okay, that makes sense. Planning is better. But what about those tricky cases? The ones you can't even feel? Tiny spots, microcalcifications showing up only on imaging. How do you possibly target those accurately in surgery?
Yeah, the nonpalpable lesions. That's where localization techniques are absolutely essential. You can't just guess.
So how does it work?
Well, it means a trip to the mammography suite before the surgery, usually the same day. The classic method, still very common, is placing a localization wire.
A wire, like literally a wire sticking out.
Pretty much. A very thin wire, often with a little hook or barb on the end, is guided right to the edge of the suspicious area using mammogram or ultrasound guidance. That wire then guides the surgeon.
I've heard those wires can be uncomfortable and sometimes they move. Between getting it placed and the actual surgery?
That's a real concern, yeah. Patient movement, positioning. The wire tip can shift, making the excision less accurate. And it's not ideal for the patient to have it in for hours.
So is there a better way now?
There is, and it's becoming much more popular. We're talking non-wire localization. Things like tiny radioactive seeds.
Radioactive. Is that safe?
Very safe. It's a tiny amount of iodine-125, for example. Or magnetic seeds, which are basically tiny coated iron particles.
Okay, seeds. How do they work?
They're implanted right at the spot under imaging guidance, just like the wire. But the big advantage is they can be placed days, even weeks before the surgery.
Oh, wow. Much more flexible scheduling.
Huge difference. And
Yeah.
no wire sticking out, no risk of it moving during transport. Then, in the OR, the surgeon uses a special probe, a gamma probe for the radioactive seed, or magnetic probe for the magnetic one, and it literally leads them right to the target.
Like a little GPS signal.
Pretty much. It's a significant improvement in accuracy and patient comfort.
So, whether it's a wire or a seed acting as the guide, the surgeon makes the cut, takes out the tissue. What's the absolute must-do step right then and there before closing up?
Specimen radiography. Intraoperatively. Cannot skip this.
X-raying the tissue that was just removed in the operating room.
Yes, immediately. Before the patient leaves the OR, you take the excised specimen, put it in the X-ray machine right there. It confirms two critical things.
Okay, what are they?
One, if you are targeting microcalcifications, you need to see those calcifications clearly inside the removed tissue on the X-ray, not right at the edge.
So if they're at the edge, you know you need to take more.
Instantly.
Right.
You go back and take a wider margin right away. Second, it confirms the localization device. The wire tip or the seed is actually in the specimen you removed. You didn't miss the target.
That real-time check must save a lot of grief. Fewer second surgeries just to get clear margins, I imagine.
Absolutely. It shifts margin assessment from something you find out about days later from pathology to something you actively manage during the operation itself.
Smart. And speaking of margins and removing tissue, especially if the goal is to save the breast, the way you make the cut matters too, doesn't it? For how things look afterward.
Hugely important. Incision planning is key, not just for getting the cancer out, but for the long-term cosmetic result.
So are there rules for where to cut?
There are guidelines, yeah. For lesions right behind the nipple, a circumareolar incision right around the edge of the areola is usually best. The scar hides well there.
And elsewhere on the breast?
Generally, you want the incision to follow the natural skin tension lines. Think curves, often concentric with the nipple, like Langer's lines.
I remember reading in SCHWARTZ's about a very specific warning regarding radial incisions, the ones that go straight out from the nipple like spokes on a wheel.
Yes, that's a critical point for aesthetics. Radial incisions are generally okay, even preferred sometimes, but only in the lower half of the breast, like pointing downwards and maybe inwards.
And definitely not in the upper half. Why not?
Because if you make a radio cut in the upper part of the breast or a curvy cut in the lower part, when that scar tissue contracts as it heals, it can pull the whole nipple-areolar complex downwards or distort it.
Oh, I see. Causes a visible displacement?
A very noticeable one, and it's tough to fix later. So avoiding those specific incision types in those zones is all about preventing that secondary cosmetic problem. It's thinking ahead.
And once the tissue is out, getting those clean margins is priority number one for stopping local recurrence. How do you make sure the pathologist knows which edge is which?
Orientation is vital. You can't just hand them a lump of tissue. The surgeon has to mark it usually with different colored inks on different surfaces, or sometimes small sutures or clips.
So they'll ink, say, the top edge blue, the side edge black.
Exactly. Like superior, inferior, medial, lateral, deep margin. So the pathologist gets the report back saying, tumor is 1 millimeter from the superior margin. The surgeon knows exactly where more tissue might need to be taken, either then or in a follow-up. It allows for precise margin assessment. Now, this is where things get really fascinating, historically speaking. The core principle of modern breast cancer surgery is this shift away from that old radical approach.
A Holstead mastectomy.
Right. Towards the current understanding, which is backed by tons of evidence, that breast conservation surgery is basically equivalent to mastectomy in terms of survival.
Equivalent survival. That still sounds a bit radical in itself, doesn't it? How can removing just the lump be as good as removing the whole breast?
It does sound counterintuitive, but the proof is incredibly solid. It comes from multiple big, well-designed studies, prospective randomized trials. The most famous is probably the NSABP-B06 trial.
NSABP-B06.
Okay. These trials directly compared breast-conserving surgery, or BCT, which you might hear called lumpectomy, or segmental mastectomy plus radiation, against the old standard, which was mastectomy.
And what did they find long-term?
Over decades of follow-up, for patients with stage 1 and stage 2 invasive cancer, they found equivalent disease-free survival and overall survival rates. No difference.
Wow, decades of follow-up showing it's just as good.
Exactly. The takeaway was huge. Survival isn't solely determined by removing every last cell locally. It's driven more by whether the cancer has spread systemically. So local control can be achieved effectively by the combination of surgery and radiation, not necessarily just by removing the whole organ.
That's a massive deal for patients. It means the choice isn't just about survival anymore. It's about quality of life, body image, psychological impact.
Absolutely. BCT allows women to keep their breast, preserve shape, often skin sensation. The cosmetic and psychological benefits are undeniable.
And this sounds like a really important, but this equivalence relies entirely on that second step, right?
100%.
Yeah.
It hinges completely on getting post-operative radiation therapy. You cannot do BCT, lumpectomy, without the radiation component. It's a package deal.
Let's emphasize that. Why is the radiation so critical? What did BO6 show about skipping it?
The data there is incredibly stark. BO6 actually had a group of patients who only got the lumpectomy, no radiation afterward.
And what happened to them?
Their rate of the tumor coming back in the same ipsilateral breast tumor recurrence was a whopping 39.2%,
Nearly 40% recurrent.
compared to only 14.3% for the women who got lumpectomy plus radiation. It's a huge difference.
So the radiation is like the safety net, cleaning up anything left behind.
That's a great way to put it. It essentially sterilizes the remaining breast tissue, zapping any microscopic cancer cells the surgeon couldn't see or remove. That's what makes the conservation approach oncologically sound, equivalent to mastectomy.
Okay, so radiation is non-negotiable for BCT. That must connect to the whole debate about surgical margins, how much tissue to take around the tumor. Surgeons used to take huge chunks, right? Driven by that fear of recurrence.
For sure. There was a long period controversy over just how wide a margin needed to be. Was it 1 millimeter, 2 millimeter, 5 millimeter, a centimeter?
Where have we landed on that now? What's the current standard?
This is a major practice change based on accumulated evidence. The current consensus standard, specifically for invasive cancer treated with BCT and whole breast radiation, is simply no tumor on ink.
No tumor on ink, meaning just microscopically clear.
Exactly. The pathologist examines the ink edges of the specimen under the microscope. If they don't see any cancer cells touching that ink, the margin is considered negative, and that's generally sufficient.
But why not take a wider margin just to be safe? Wouldn't 2 millimeter clear be better than just not touching?
It feels like it should be, intuitively. But large studies and meta-analyses looked at this specific question. They found that for patients getting that essential whole breast radiation, going for wider margins beyond just no tumor on ink did not further reduce the risk of local recurrence.
Really? So taking more tissue didn't add extra protection?
Not in a statistically significant way, no. The radiation is doing such a good job controlling that microscopic residual disease that wider surgical excision mainly just compromises the cosmetic outcome without improving the cancer outcome.
That's a crucial balance then. Minimal effective surgery plus radiation maximizes both cure and appearance.
Precisely. Oncological safety with the best possible aesthetic result.
But BCT isn't for everyone. Even though it's often preferred, there are situations where mastectomy is still necessary, or maybe even the better choice. What are the main reasons someone can't have BCT?
Right, there are contraindications. Some are absolute, meaning BCT is definitely not an option.
Like what?
The big one is prior radiation therapy to that same breast or chest wall area. You generally can't safely radiate the same tissue twice to those high doses.
Makes sense. What else?
Persistently positive margins. If the surgeon tries multiple times to get clear margins with re-excisions and still can't, then mastectomy might be the only way to ensure all the cancer is removed. Also, multicentric disease.
Meaning cancer in multiple spots in the breast.
Yes, distinct tumors in different quadrants that are too far apart to be removed through a single cosmetically acceptable incision. Taking them all out would basically deform the breast anyway.
Okay, those are the absolutes. What about relative contraindications, where it's more of a judgment call?
Certain active collagen vascular diseases can be a big issue. Things like scleroderma or severe lupus. Radiation can cause really severe reactions and poor healing in those patients.
So the radiation part becomes too risky.
Exactly. And then there's the tumor to breast size ratio. If someone has a very large tumor in a relatively small breast, even getting a negative margin might require removing so much tissue that the cosmetic result of BCT would be, well, quite poor. In that case, mastectomy with reconstruction might actually offer a better aesthetic outcome.
Patient preference plays a role too, I assume.
Absolutely. Some women, even if eligible for BCT, simply feel more comfortable psychologically with having the entire breast removed. That choice needs to be respected.
So if BCT is out and the patient needs a mastectomy, let's talk about that procedure. We mentioned the old Hosted radical. What's the standard mastectomy today? The modified radical mastectomy.
Yes, the modified radical mastectomy, or MRM, is the workhorse procedure when mastectomy is needed. The key difference from the Halsted is muscle preservation.
Okay, how so?
The MRM removes all the breast tissue and typically the axillary lymph nodes levels 1 and 2 and sometimes 3. But crucially, it preserves the pectoralis major muscle, the main chest muscle.
And preserving that muscle makes a big difference.
Huge difference. Functionally, it means better arm and shoulder strength. less of a hollowed-out chest wall appearance, and it provides much better coverage and support for immediate breast reconstruction.
How do surgeons get access to those higher lymph nodes, level 3, way up in the armpit, without sacrificing the pec major? I thought the pec minor muscle was in the way.
Good point. Often they use a specific technique, sometimes called Patey's modification. It involves dividing or sometimes removing the smaller pectoralis minor muscle.
Ah, sacrificing the smaller muscle to save the bigger one.
Essentially, yes. Dividing the pec minor gives much better exposure to get clear access to those level 3 apical nodes. It ensures full oncologic clearance of the axilla while still preserving the functionally more important pec major.
Got it. And even within mastectomy, there are newer techniques focused even more on appearance, right?
Right.
Especially for reconstruction.
Definitely. We're seeing more and more skin-sparing mastectomy and nipple-areolar-sparing mastectomy.
Saving the skin envelope or even the nipple itself?
Exactly. These are often great options for women having risk-reducing prophylactic mastectomies or for those with smaller, early-stage cancers located far away from the nipple.
What's the advantage?
By preserving that natural skin, or the nipple-areola complex, you give the reconstructive surgeon the absolute best possible canvas to work with for immediate reconstruction. The cosmetic results can be fantastic.
But I imagine saving the nipple isn't always possible or safe.
Correct. You need to be sure there's no cancer involving the nipple ducts. And importantly, patients who are likely to need post-mastectomy radiation therapy are often not ideal candidates for nipple-sparing surgery. The radiation can compromise blood flow and lead to nipple necrosis or loss. So patient selection is key.
Okay, moving from the breast itself to the lymph nodes in the armpit, the axilla, this area. Wow, the changes here have arguably had the biggest impact on patient quality of life, wouldn't you say?
I think that's absolutely fair to say. The shift in how we manage the axilla is a massive success story in reducing surgical harm.
Because for decades, the standard was axillary lymph node dissection, ALND. If there was any suspicion, you basically cleared out most of the nodes.
That was the teaching, yes. Levels IN2, sometimes 3. It was considered essential for staging and regional control.
But it came at a steep price for the patient. What was the main complication?
The big one, the dreaded one, is lymphedema. Chronic, sometimes severe swelling of the arm on that side.
How common was it?
It varied, but SCHWARTZ quotes around 20% incidence after ALND alone. But if the patient also needed radiation to the axilla after the surgery, that risk could shoot up dramatically, maybe 50%, even 60% in some series.
Half the patients getting chronic, potentially debilitating arm swelling. That's staggering.
It is. And besides lymphedema, there's risk of nerve damage during that dissection.
Which nerves are we talking about?
Two main ones to be really careful about. The long thoracic nerve, if you injure that, the patient gets a winged scapula because the serratus anterior muscle is paralyzed. Big functional deficit. And the thoracodorsal nerve, which supplies the latissimus dorsi muscle, important for arm movement and often used in reconstruction. Damaging either causes permanent functional problems.
So the goal became, how do we find out if cancer has spread to the nodes without doing that massive dissection in everyone?
Exactly. We needed a way to accurately sample the nodes that were most likely to be involved first. That led to the development of sentinel lymph node dissection, or SLND.
The sentinel node, the first guard post, basically.
That's the concept. It's the first lymph node, or nodes, that receives lymphatic drainage directly from the tumor site. The theory is, if the cancer is going to spread through the lymphatics, it has to pass through that sentinel node first.
So if the sentinel node is clean,
then it's highly, highly likely that all the other nodes further up the chain are also clean. It predicts the status of the entire axilla very accurately in clinically node-negative patients.
Which means you can avoid the full ALND if the sentinel node is negative.
Precisely. And SLND is now the standard of care for staging the axilla in patients who don't have, obviously, swollen or cancerous nodes on exam or imaging beforehand.
Okay, how does the surgeon actually find that specific sentinel node? It must be like finding a needle in a haystack in the fatty tissue of the armpit.
It requires a mapping technique. Usually we use a dual agent approach for the best accuracy.
Dual agent, meaning two things.
Yep. First is a radioactive tracer, typically technetium 99-meter labeled sulfur colloid. It's a very low-dose radioactive substance injected near the tumor or around the areola, usually a few hours before surgery.
And it travels through the lymph channels?
Exactly. It follows the same path the cancer cells would take and gets trapped in the first node. It encounters the sentinel nodes.
How do you detect it in the OR?
With a handheld gamma probe, It's basically a small Geiger counter that makes noise, usually a high-pitched beep, when it gets close to the radioactive signal concentrated in the sentinel node.
Okay, that's agent one. What's the second?
The second is a visual tracer, a blue dye, isosulfan blue or methylene blue. This is injected right before or at the start of the surgery, again near the tumor or areola.
And you can actually see it.
You can.
Yeah.
It stains the lymphatic channels blue, and the sentinel node itself often turns visibly blue. So the surgeon is looking for nodes that are both hot, radioactive, and blue. Sometimes a node is only one or the other, and those should generally be removed too.
So you take out anything blue or radioactive. How many nodes does that usually end up being? Just one.
It varies, but usually it's between 1 and 4 nodes. There's a guideline often called the 10% rule.
The 10% rule.
Yeah, the surgeon removes all the blue nodes, the hottest node, the one with the highest radioactive count, and any other node that has a count greater than 10% of that hottest node's count. This ensures you get the most relevant nodes. Removing just one node might not be enough sometimes.
Is the procedure safe? The radioactive tracer, the glue dye?
Very safe. The radiation dose is minimal, less than many diagnostic scans. It's even considered safe during pregnancy, using just the colloid without the blue dye. The blue dye carries a very small risk of allergic reaction, maybe 1 in 10,000, so we watch for that. But serious reactions are rare.
Okay, so SLND was a huge step forward, dramatically reducing unnecessary ALNDs and lymphedema for node-negative patients. But then came a trial that questioned whether we even needed ALND if the sentinel node was positive, which sounds completely backward.
Right. That was the American College of Surgeons Oncology Group, ACO-SOG Z00 truly practice-changing.
What did Z00011 look at specifically?
It looked at a very specific group of women, those with smaller primary tumors, T1 or T2, who had no palpable nodes before surgery, clinically N0, and were planning to have breast-conserving therapy lumpectomy plus whole breast irradiation.
Okay.
During their SLND procedure, these women were found to have cancer in only 1 or 2 sentinel lymph nodes, limited nodal disease.
Traditionally, finding positive nodes, even just 1 or 2, meant you automatically went back for the full ALND, right?
Absolutely, that was standard practice. But Z0011 randomized these women. One group got the completion ALND, the other group got nothing further done in the axilla, just the SLND they already had.
And the results, this is the mind-blowing part.
The results showed absolutely no difference in survival outcomes between the two groups. Overall survival and disease-free survival were statistically identical whether they had the full ALND or just the SLND.
No survival benefit from removing the rest of the nodes? How is that possible?
The thinking is that in this specific context, small tumor, only minimal nodal disease, and crucially treatment with both whole breast radiation, which incidentally treats part of the lower axilla, and effective systemic therapy, chemo or hormonal therapy based on tumor characteristics, those treatments were likely sufficient to eradicate any tiny remaining cancer cells in the non-sentinel nodes.
So the additional surgery wasn't adding any meaningful benefit, just harm.
Precisely. And this leads to a really important question someone might ask. If the radiation and systemic therapy are doing the heavy lifting for residual nodal disease, why do SLND at all? Why not just skip axillary surgery altogether in these patients?
Yeah, why bother finding out if 1 or 2 nodes are positive if you're not going to act on it surgically?
Because the SLND still provides critical prognostic information. Knowing the end stage, the number of positive nodes, is incredibly important for deciding the type and intensity of systemic therapy the patient needs.
So it guides the chemo or hormone therapy decisions.
Exactly. A patient found to have 3 positive nodes via SLND might get a very different, more aggressive systemic treatment plan than someone with 0 positive nodes, even if neither ends up getting an ALND thanks to trials like Z0001 or others that came after. SLND tells us how aggressive the cancer might be systemically.
Okay, that makes sense. So if Z011 showed no survival difference, what was the big advantage of skipping the ALND in those patients with 1-2 positive SLNs?
The morbidity, the side effects, that's where the difference was huge.
Lymphedema again?
Lymphedema, primarily. In Z0011, the rate of patient-reported lymphedema was only about 2% in the SLND-only group. But in the group that got the completion ALND, it was 13%.
Wow, a 6-fold difference, 2% versus 13%.
Massive difference in quality of life, reduced numbness, pain, shoulder stiffness too. It proved you could safely avoid a morbid surgery in a selected group of patients without compromising their cancer outcome. It completely changed guidelines and practice worldwide for patients meeting those Z0011 criteria. #4, surgical integration and reconstruction.
Okay, so we've covered diagnosis, the choice between lumpectomy and mastectomy, and the evolution of managing the lymph nodes. Let's talk about putting it all back together, reconstruction. This feels like a really integrated part of the process now, not just an afterthought.
Absolutely. The philosophy he shifted entirely. Reconstruction isn't separate from the cancer treatment. It's often considered an integral part of the cure and the patient's recovery, addressing both physical and psychological well-being.
And the timing seems important. Immediate versus delayed reconstruction.
Yes, and generally, immediate reconstruction, doing it at the same time as the mastectomy, is preferred whenever possible.
Why immediate?
Several reasons. Cosmetically, you often get a better result because you can preserve the natural skin envelope using those skin-sparing techniques we talked about. Psychologically, it can be incredibly beneficial for the patient to wake up from surgery already having a breast man formed rather than facing a flat chest wall.
So it helps with body image right away.
Tremendously. It can ease the sense of loss and contribute to a faster emotional recovery for many women.
But it's not always possible to do it immediately, right? What's the main obstacle?
The biggest factor influencing timing is the potential need for post-mastectomy radiation therapy, or PMRT.
Radiation again. How does that interfere with immediate reconstruction?
Radiation can be quite damaging to reconstructed tissues, especially implants. It increases the risk of complications significantly, things like capsular contracture.
That's when hard scar tissue forms around an implant.
Exactly. It can make the reconstructed breast hard, misshapen, painful, and ride high on the chest wall. Radiation also increases the risk of implant infection, extrusion, and just generally leads to a poorer aesthetic outcome if an implant is present during treatment.
So if a patient is likely to need PMRT, say, for a larger tumor or multiple positive nodes, what's the strategy?
In that situation, reconstruction is often delayed. But surgeons will usually try to preserve the option for a good reconstruction later.
How?
A common approach is to place a tissue expander at the time of the mastectomy. This is basically an empty silicone balloon placed under the skin and muscle.
To hold the space, keep the skin stretched.
Precisely. It preserves that skin envelope. Then, during radiation, the expander might be kept partially inflated with saline, or sometimes even deflated, to allow the radiation to reach the chest wall effectively without the implant blocking it.
And then the final reconstruction happens later.
Yes, typically 6 to 12 months after radiation is finished, once the tissues have healed and settled down. The expander is removed, and the definitive reconstruction, often using the patient's own tissue, is performed then.
Okay, let's talk about those definitive options. What are the main choices for rebuilding the breast?
Broadly, it's two categories. Implant-based reconstruction, using silicone or saline implants, often placed after tissue expansion.
Which is common if radiation isn't needed.
Right. Or autologous reconstruction, using the patient's own tissue harvested from another part of their body.
Autologous meaning from self. Where does this tissue usually come from?
The most common donor sites are the abdomen or the back, sometimes the buttocks or thighs.
Why use the patient's own tissue? What are the advantages, especially if radiation was involved?
Autologous tissue is living tissue. It brings its own blood supply, it heals well, it feels softer and more natural than an implant, and it changes with the patient over time, like if they gain or lose weight. Crucially, it tolerates radiation much, much better than an implant does.
So it's a more resilient, living reconstruction.
Exactly. Let's talk about the abdominal flaps, as they're very common. The older technique is the tram flap,
TRAM, what does that stand for?
transverse rectus abdominis myocutaneous flap. It takes a paddle of skin and fat from the lower abdomen, similar to a tummy tuck,
Okay.
but it also takes a portion of one of the rectus abdominis muscles, the six-pack muscle, because the blood supply to the skin runs through that muscle.
Taking muscle sounds like it could cause problems.
It can. That's the main downside of the tram flap. Sacrificing part of the abdominal wall muscle can lead to weakness, bulging, and a higher risk of hernias down the line.
So is there a way to take the abdominal tissue without taking the muscle?
Yes, and that's the more advanced preferred technique today for many surgeons and patients. The DIEP flap,
PIEP.
deep inferior epigastric perforator flap. This is a highly sophisticated microsurgical technique.
How does it work?
Like the tram, it uses the skin and fat from the lower abdomen. But instead of taking the whole muscle chunk, the surgeon meticulously dissects out only the tiny blood vessels, the perforators that run through the muscle to supply the overlying skin and fat. The muscle itself is largely spared.
Wow, that sounds incredibly delicate, teasing out tiny blood vessels.
It requires specialized microsurgical training and skills, yes. Those tiny vessels on the flap then have to be reconnected, sewn under a microscope, to blood vessels in the chest wall to keep the flap alive. It's complex.
Like intricate plumbing, as you said earlier. What's a big payoff for all that complexity compared to the tram?
The payoff is primarily at the donor site, the abdomen. By preserving the rectus muscle, you significantly reduce the risk of that long-term abdominal wall weakness, bulging, and hernia formation. Patients tend to recover core strength much better. It's a longer, more complex surgery, but the functional outcome for the abdomen is generally superior.
What about tissue from the back? The latissimus flap.
The latissimus dorsi flap is another option. It uses the large muscle of the back, along with an overlying paddle of skin and fat. It's often swung around to the front to create the breast mound.
Does it provide enough volume on its own?
Often, no. The latissimus muscle itself isn't usually bulky enough to create a full breast mound matching the other side, so it's frequently combined with an implant placed underneath it for additional volume. It's a reliable flap, but it does involve sacrificing a back muscle, which can have some functional implications, and it leaves a scar on the back.
So lots of options requiring careful discussion with the plastic surgeon.
Absolutely. It's a very personalized decision based on the patient's anatomy, cancer treatment plan, especially radiation, lifestyle, and goals.
We've focused on reconstruction after mastectomy, but what about improving the cosmetic outcome after a lumpectomy, especially if you had to remove quite a bit of tissue?
Yes. That's where oncoplastic surgery comes in.
Oncoplastic, meaning combining oncology and plastic surgery principles?
Exactly. It integrates plastic surgery techniques right into the lumpectomy procedure itself. If removing the tumor and achieving those clear margins means taking out a significant chunk of the breast, say 20% or more of the volume, just closing the defect can leave a really noticeable dent or distortion.
So what does oncoplastic surgery do instead?
Instead of just closing the hole, the surgeon uses techniques to reshape the remaining breast tissue. This might involve mobilizing local tissue flaps within the breast to fill the defect, or sometimes performing techniques similar to a breast reduction or lift on the affected breast at the same time as the lumpectomy.
To maintain shape and symmetry.
Precisely. The goal is twofold: ensure complete cancer removal with negative margins and achieve the best possible aesthetic outcome, minimizing deformity and often improving symmetry with the opposite breast. Sometimes a matching procedure on the other breast is done at the same time or later for better balance. It really prioritizes both cure and form. Hashtag tech outro.
Wow, okay, so listening to all this, it's clear that the surgical journey for breast cancer has become so much more nuanced, so much more data-driven than it used to be.
It really has. We've moved leaps and bounds from the one-size-fits-all radical approach of the past.
So let's try to synthesize the big takeaways from our deep dive today based on what SCHWARTZ and the evidence show us. What are the absolute key advancements?
Okay, first and foremost, the survival equivalence. Decades of data, like from NSAB B006, confirm that for many women with early-stage cancer, breast-conserving therapy with radiation offers the same survival as mastectomy.
That's foundational. Choice based on quality of life, not just survival.
Absolutely. Second, the ability to precisely target and confirm removal of nonpalpable lesions. Using wire or seed localization, guided by imaging, and critically confirming removal with intraoperative specimen X-rays. That ensures accuracy.
Right, hitting the target accurately. What's third?
The revolution in axillary staging, sentinel lymph node dissection. It drastically cuts down on the morbidity, especially lymphedema, compared to the old routine axillary lymph node dissection.
And the 0011 trial took that even further.
Exactly. 00011 showed that for specific patients, BCT candidates with only 1 or 2 positive sentinel nodes getting whole breast radiation, you can safely skip the completion ALND altogether. No survival compromise, but a huge reduction in side effects.
Game changer for those patients. And finally,
The integration of reconstruction. Immediate reconstruction, often using sophisticated techniques like skin sparing or nipple sparing mastectomy, and advanced microsurgical flaps like the DEP flap, makes restoring form a core part of the initial treatment, especially navigating the challenges of radiation.
it's all about maximizing both cure and long-term quality of life.
That's the driving force, which, raises a really interesting question for the future.
Go on.
Well, as our surgical approaches become less invasive, as we get better at managing the axilla with less intervention, and survival rates continue to improve, how much of the focus now needs to shift? Will the next frontier be less about radical cure, which we're achieving, and more about truly minimizing all the secondary effects, even the minor ones?
You mean things like subtle lymphedema, chronic pain, nerve issues, fatigue? The things that impact daily life even after being cured.
Exactly. Are we moving into an era where maximizing long-term functional recovery and addressing those persistent quality of life issues becomes the primary challenge now that basic survival is so much better?
That's a really powerful thought to end on. It highlights that the progress isn't just about living longer, but living better after cancer. And for you, the listener, the key thing to appreciate is how this evolution wasn't guesswork. It was driven by rigorous science, by clinical trials like B06 and 0011 that meticulously compared approaches and allowed us to safely choose less invasive paths.
That evidence is what empowers doctors and patients to make these incredibly personalized decisions, balancing cure with function and form in a way that just wasn't possible before.